I'm Matt Okelberry, work for Mountain Land Physical Therapy. I now do full-time EMG nerve conduction studies. Spent some time in Nashville doing a residency for this specialty. So it's pretty much exclusively what I do now. Dr. Schwar gave an awesome introduction to EMG and nerve conduction studies last week, which is perfect, so we can kind of get most of our time into a demonstration and a couple discussion items on what EMGs can teach us about nerve root pathology when we're working up patients with spine pain and radiating pain. So this is a quick review. This is a diagnostic test of the peripheral nervous system. There's two parts to the test. The first part, we're actually going to jump forward here, nerve conduction. So we have electrodes placed distally over specific muscles or nerves. We stimulate the nerve upstream, and we can get a bunch of data on how that nerve conducts downstream, conduction velocities, amplitudes, and much more. And then we can compare that data to established normative values, compare side to side. And then the second part is EMG, electromyography. So if you break that word down, electric properties of the muscle. Basically, a needle electrode is inserted into a muscle and records the electric activity in that muscle and converts that into sound and waveforms, which you'll see here in a minute. And the electrical behavior, so to speak, of that muscle tells us about the health of the nerve tract that innervates that muscle. So when I'm checking out the deltoid muscle, I'm learning about the radial nerve, the posterior cord, all the way up to C5 and C6 nerve roots. And so when we get kind of a broad sample of multiple muscles in the arm or leg, we can see kind of what the common denominator, so to speak, of the abnormalities and what nerve the problem is coming from. What are some barriers to using EMG diagnostics? Just discuss real quick. Needles, yeah. Definitely. Other thoughts off the top of your head? Yeah.
We've historically had barriers to scheduling an EMG with a provider. I think because of you and others, there's less of that, but it's a diagnostic test. It is a good piece of information to have, but then when you go to schedule an EMG and find out it's going to be 6 weeks or something, then it's like, well, do we really need it? So that's been one issue that we have had in the past.
Yeah, definitely. And we're trying to whittle that down significantly and make it more accessible for people, location and timeliness. This is the big one we get a lot. Does it hurt, right? Do I want to send my patient for a diagnostic test that's very uncomfortable? Is that worth the value that we get and the information from the EMG report? So with that said, we're hoping to answer a lot of this by demonstrating. Brandy was kind enough to volunteer, and she can tell us a little bit about her experience after. And then
no judgment if there's tears.
Also done a demo on Tyler and Alex, so feel free to chime in on your experience as well. So with that, we'll jump right into the demonstration. So I've already kind of measured Brandy's arm with different measurements. We are calculating conduction velocities, so we need known distances that are standardized so that we can use normative values and such. So if you want to lay on your back here, Brandy, and then first, we're going to test her median nerve. So we generally use a distal superficial muscle. The abductor pollicis brevis in the hand is kind of the standardized way to test the median nerve. And I'm just going to set this underneath your arm. We'll get her hooked up to the electrodes. And then from here, I'm just going to go through a couple nerves, kind of the same way that I would go through with a patient, explaining kind of what we're doing and what it feels like as we go. So So Brandy, the first part of this test, we'll do little zaps up and down the arm to see how your nerve is responding.
Excellent.
Okay. Starting in the palm of the hand, it starts off small, kind of tappy feeling, and we'll just get gradually a little bit stronger. As it gets stronger, you'll feel your thumb twitching. And then we're seeing a nice response come there from the median nerve. And then I'm coming down to the wrist. This one is the same thing. It feels a little snappier just because the skin is a little thinner at the wrist. Good. And then I'm going to come up to the elbow. This one's kind of a big jump. It hits more muscles downstream. A little pop here. One more. I lied, 2 more. Brandy's got a tricky nerve here. There it is. All right, so there's the median nerve. Looks great. We're gonna adjust that a little bit. Okay, very good. And then we would do kind of a thorough screen with a full study here. We're just gonna jump down. So that was the motor fibers of the median nerve. Now we're gonna switch and test the sensory fibers of that nerve. We have a little bit of different electrodes for this one. This is the hardest part of the test for me, not tangling all the wires.
That's what Spencer comes in for, right?
Yep. All right, so we're going to use the third digit for testing sensory fibers of the median nerve. This is just a little ultrasound gel. And then these are just like the stickers, they just work better on your fingers. And then this feels pretty much the exact same as what we did before. A little snappier here. Brandy has great looking nerves.
Yes. Never thought anyone would say that about me. Best compliment today.
So here, this one is, like I said, very normal. If they had some slowing across the carpal tunnel, for example, this response here is the stimulation in the palm, and then this one down here is down proximal to the wrist. So if there was slowing across the carpal tunnel, we would see this response come in further to the right. If there was demyelination and that nerve was slower getting across that demyelinated segment, and we would see that reflected in some of these numbers. This would be, higher than this 3.6. This would have a slower conduction velocity, and then we'd want to corroborate that with other sensory nerve testing. For example, we can test the thumb, which is innervated on this side by the median nerve, and then the superficial radial on the dorsal side. We can do the same distance and compare the time that it takes to get to that digit. And if the superficial radial nerve gets there long before the median nerve, that's another piece of evidence that that median nerve is slowed across the carpal tunnel, and kind of solidifies our conclusion there. So that's the nerve conduction piece. We can do this on, all of the major nerves, ulnar, radial, and all the sensory nerve branches.
Brandy, did it hurt? No.
Yeah, so Brandy, if you want to sit up here, let me get you unhooked and tell us about the nerve conduction, and then we'll show the EMG part.
Definitely didn't hurt at all. Weird sensation for sure. I'm trying to think of what it would be akin to. Have you ever grabbed like one of those electrical fences? Feels a little bit like that. Did that when I was a kid. But not really painful. Just like kind of a weird zap.
More weird than painful.
Weird, yeah.
Yeah.
Weird sensation. Not painful.
For sure.
Sticking your tongue in a 9-volt battery.
Yeah.
There you go. Yeah. Cool. All right, well, let's switch gears to the EMG portion. You can come on back down there. Get this underneath you again. And then the way I describe this part is with a tiny needle electrode. It's about acupuncture size. We'll go into some of the muscles and listen to the electric activity in your muscles. Some of them you might not even feel. Some of them are a little bit tender. And then you can just rest your hand right there. Check out a few arm muscles here. So Dr. Shwari last week introduced this a little bit. We look at the muscle when it's at rest and when it's contracted to analyze the motor unit activity. All right, so we're going to start in the deltoid here, a little prick here. And usually we have a pretty flat baseline with other electrical stuff plugged in. It'll be a little wobbly, but we can still get the main idea. So we're going to advance the needle and then let that shoulder relax all the way. So a normal muscle at rest is electrically silent. So except for when I'm moving the needle, right there, there's nothing going on in that muscle, except for when Brandy is tense. There we go.
All the time.
So now, just lightly push your elbow out into my hand. So now we hear some motor units fire up. Just push super small, a little bit less. If we can kind of get 1 or 2 motor units, we can get a feel for how fast those are firing and look at the morphology, kind of the shape of those motor unit potentials to see if they're normal or abnormal. Brandy's look great, and honestly a lot stronger than Alex and Tyler's. So there's the deltoid. We'll just do a couple more. We'll do triceps here. Another poke. So we're in muscle tissue here, electrically silent when the muscle's at rest. If we did see spontaneous, rhythmic, there's a couple characteristic electrical potentials that we're looking for here, and those tell us if the muscle is not under active neurologic control and is deinnervated or the muscle membrane is unstable, and that would clue us in that there is a problem somewhere along this nerve track going up. Okay, now I'll have you push lightly towards your feet. And then give me a strong push now. Good. So start light again. So as one motor unit fires up, remember the more force you're trying to generate, the faster motor units fire and the more recruited. So go a little harder now. So now we get 2 or 3 motor units going, and then the harder she pushes, we get so many that we can't really distinguish them. And again, looking great there. All right, don't look as I recap a needle. All right, so let me get you unhooked, Brandy, and you can tell us again kind of what the EMG needle portion feels like. All right.
Honestly, if he didn't tell me that there were needles, I wouldn't have known. Those were tiny. You can't really feel that it was a needle. So that didn't hurt at all, or feel uncomfortable even.
Yeah, so especially in larger muscles, like you said, sometimes you don't even know that the needle has been placed.
Yeah.
There are some more tender ones if we have to check out some in the hand or the foot. You feel them a little more, but that would be as bad as that gets. Anything else you want to tell us about your experience?
Probably a little bit more weird when it's done in front of a room of people. But beyond that, like it really didn't hurt, wasn't uncomfortable. So reassuring for patients.
Awesome. Thank you.
Yeah, thank you. Am I down here?
Yes.
All right.
Thanks. Cool. Let's go over here now. So let's talk about a couple specific things with EMG and radiculopathies. Electrodiagnostics has modest sensitivity for radiculopathies, shows kind of the specific percentages there for lumbar and cervical radiculopathies, but excellent specificity. So if you remember back to kind of those statistics, if something is highly specific and you get a positive test, you can with a large degree of certainty rule that condition in. Right? So when we find a radiculopathy with an EMG, it's there. If we get a normal EMG, it could be a false negative, meaning that a radiculopathy can be kind of under the threshold of the sensitivity of an EMG to detect, and we'll talk about why that is here. So let's review a little bit of the anatomy of a spinal nerve root. So here's a cross section of a lumbar vertebrae and the nerves coming out there. So the motor neurons are going to be in the anterior horn, right? And they're going to come out the anterior root and combine with the dorsal root, which has inbound sensory neurons. And that combines to make the spinal nerve root right there before it divides into the anterior rami, which in this case is going to go down into the lower extremities, and the posterior rami, which goes to innervate the paraspinals. This swelling here on the dorsal root here is the dorsal root ganglion. And here, inbound sensory fibers are going to synapse with another sensory neuron and then continue into the spinal cord. So when we test motor and sensory nerve fibers down in the leg, we demonstrated on Brandy's arm. And so when I was checking those sensory nerves, those are not the same sensory nerves that end up in the spinal cord, because it's going to synapse with that second one in the dorsal root ganglion close to the spinal cord here, and then continue in. And so the sensory nerves that we're testing are not the ones that would be affected by a radiculopathy happening right here. And so a characteristic pattern when we're doing EMGs of a radiculopathy, you might have diminishing of the motor responses, but the sensories would be spared because the sensory nerve that you're testing is not the one affected by a disc herniation or whatever is causing that nerve root impingement. So generally, here's kind of a simplified progression of nerve injury. Generally, sensory fibers are affected first. Like if we take carpal tunnel, for example, a mild carpal tunnel syndrome would just involve sensory nerve fibers before it advances to involve motor nerve fibers as well. And then generally, first you get demyelination occurring at the nerve, and then as that advances, you'll start to get axon loss in the nerve. So if sensory fibers are generally affected first, and we can't assess sensory fibers in a radiculopathy, a mild radiculopathy would not be present on an EMG. So what does this mean for spinal nerve root compromise, and how does this change how we interpret a normal EMG study? Any thoughts on kind of what we would do with this information when we're looking at an EMG report and suspecting nerve root impingement?
Yeah, I think that's really helpful information. I don't think I ever knew that. And so being able to explain that to patients that, hey, this does not completely rule out that you may have a radicular process is really good information.
Yeah. And it kind of begs the question, why do we use it then if it's not going to catch some of those more mild cases? I think it's still very valuable because if we get a normal EMG, either the nerve root is not involved or it is to a more mild, lesser extent, and likely either scenario, conservative management of that is more justifiable than talking about next level care if there's motor nerve involvement and deinnervation down in those myotome muscle groups. Any other thoughts on how this might impact how we manage? Yeah.
I think there's also like a temporal aspect to things as well. If there's an injury, usually it takes a couple of weeks to show up on the EMG, or that's what I've been told.
Yes.
2 weeks usually.
Yeah, especially the EMG portion. Those electrical signals that we're looking for aren't going to show up until a few weeks have passed, where you get the Wallerian degeneration and the change in the muscle membrane. So yeah, timing of the EMG is certainly important. Usually by the time a patient comes in, they're worked up, you order an EMG, they schedule an EMG and come for that appointment. It's been 3 weeks. It's pretty unusual that they would beat that timing anyway. But yeah.
I have kind of a comment and a question. So it's pretty common for us to treat, say, a lumbar radiculopathy surgically and have the patient come back and say their radicular pain is better, but they still have some numbness, or they still have some weakness, and they think that something's still not right. It's nice to know that the sensory portion might not be detected on an EMG. How would you counsel a patient in that situation? And how would the nerve conduction study in EMG be helpful or not helpful?
Yeah. The next part we'll talk about with how the motor units remodel and reorganize after a nerve injury will help with that as well. But with this information, we know that sensory fibers are also the last to heal. And so those are going to take longer for the sensory fibers to normalize if they do. And so sometimes the sensation, numbness, pins and needles type of things will linger longer than the acute kind of pain and weakness will.
I've always told patients that, but if I'm honest, I've never fully understood why. Is it just that the sensory nerve fibers within the nerve bundle are not as capable of healing, or are they damaged earlier in the process and not detected, or do you know why that takes longer to heal?
Yeah, I don't know if I have a great answer. They are significantly smaller than the motor nerve fibers, and so I don't know if it's the vascular component of that supply to get healing, or they get damaged sooner, and so they undergo kind of a longer time frame of nerve damage before that's corrected. And if it's been too much time, then any nerve is not as likely to regenerate and normalize.
I comment, sorry, to answer your question. A lot of it depends on what injury you begin with. Like you said, demyelination versus axon. So a lot of times the EMG portions, which are the second part, will show if there's polyphasic units. So in that case, if there's axon injury, those patients typically take much longer because the axon regrows is so slow, 1 millimeter for several days. It will take quite some time for this patient to get there. So if we see them by 6 weeks after surgery, it just might be that if EMG shows that it's axon versus myelin, and that relates to both sensory and motor fibers. So it's probably maybe I don't know if the sensory fibers that are involved are more demyelinating, like muscle lesion. But if you have a really bad disc herniation pushing to the axon, it may take a long time. A patient come back, your surgery is perfect, but it still has symptoms. A lot of it could be the regrowth pattern. And EMG can easily show there's axon damage versus myelin.
Yeah, thank you. This is, I'm sure, familiar to you. This is the frequency of finding abnormalities on MRI in patients that are asymptomatic, right? So if we look at, disc bulges or herniations, for example, by the time we're in our 30s and 40s, maybe half of us are walking around with some disc herniations and, we're fine, we don't have symptoms. And then by the time we get into kind of the later decades of life, almost be considered pathologic to not have all this stuff going on, right? And so I think this, combined with Diagnostic imaging combined with diagnostic EMG can be really valuable, because if we see abnormalities on the MRI, but if it's unclear if that abnormality we see is the culprit of the patient's symptoms, then we can corroborate that with the function of the nerve from the EMG report and start to complete the picture. Let's talk just for a minute about acute versus chronic EMG findings. When I was demonstrating on Brandy, when the muscle's at rest, we're looking for those characteristic electrical potentials that tell us that the muscle doesn't have active neurologic control, that somewhere along that nerve track there's axonal damage and changing how the electrical behavior of the muscle responds. And then when they activate that muscle, we're seeing those motor units, and we can analyze the firing rate and the morphology, which tells us about the size of the motor unit. So here's a little illustration that might help. So this is a healthy, intact motor unit. There's 3 neurons here that are innervating multiple muscle fibers, and motor units have overlapping territories. And then this is what it might look like on an EMG. We see different motor unit potentials. And then if there's axon loss, so we have 2 of these 3 neurons that are compromised, and so there's only 1 motor unit trying to do the work that multiple were before, we're going to see that 1 motor unit firing really fast to produce the same amount of force that multiple were involved in previous to the nerve injury. And then if we fast forward 6 or more weeks down the road, this healthy motor unit, or that one that's not completely compromised, is going to have what's called distal collateral sprouting, where this is sending off nerve sprouts that can pick up de-innervated muscle fibers. And so this has happened here. So these muscle fibers that were previously innervated by these 2 neurons are now all part of this 1 motor unit that is much larger territory than the original one here, right? So when we activate this on EMG, we're going to see still 1 firing very fast, and the size of this motor unit is much larger. You're going to see the duration of that potential and the amplitude and the number of phases and this motor unit potential all increase, because this motor unit has a much larger size and territory than it previously did. So kind of the last question I wanted to get some thoughts on: if we perform an EMG, say this was an L5-S1 radiculopathy, and we see chronic motor unit remodeling, so we're finding these type of things on the EMG, but we don't see any acute findings, nothing that suggests that there's ongoing active axon loss. How does that change management of a patient with a chronic versus an acute radiculopathy?
From a surgical setting, it gives us a little bit of pause when there's chronic findings of just how aggressive we're going to be intervening surgically.
Yeah.
I think obviously imaging is important in that aspect, but definitely something that we use to make our decision as acute versus chronic.
Yeah, thank you. Alex?
Setting the patient expectation as well, which goes into that, because we were just talking about the recovery of something that's chronic, but somebody says, my leg has been asleep for 5 years, I think I want to do surgery now. And you got to kind of say, well, I think you might have a different expectation than of what we would get out of that.
Right. Yeah, I agree. It definitely gives pause and a difference in how we're communicating to that patient and making decisions and how the care goes forward. If the body's already doing what it's supposed to do and adapting from that nerve injury, and those changes have happened, and we don't see an ongoing evidence of nerve insult, that, like Tyler said, may kind of pump the brakes on that next level care. So, all right, thank you everyone.